Yeah, now you are audible.
Good evening. Thank you all so much for, having this meeting.
Yes.
Are my slides seen?
We can.
Yeah, seen, visible.
Okay. So thank you so much for, having this wonderful idea of having a meeting on the International Epilepsy Day. And Dr. Biradar asked me to talk about epilepsy, a general overview. Now, the topic is very broad, so I will be giving key messages from key areas where there has been a change from before. I bring greetings from my Center of Excellence for Epilepsy at AIIMS, Delhi. Now, the most important thing is that the definition itself of epilepsy is something that has undergone a change in the past decade. That is in 2014, it has been redefined as a condition where there are two unprovoked seizures or reflex seizures occurring usually more than 24 hours apart, or even a single seizure. So previously, a single seizure was not classified as being epilepsy. But in the new definition, even a single seizure is defined as epilepsy. And it's particularly if the clinician or the physician and the neurologist determine that the chance of recurrence is as high as 60%. So the diagnosis, if the patient has a diagnosis of an epilepsy syndrome, like an absence or a mesial temporal sclerosis syndrome or a Panitopolis syndrome, then also the person has epilepsy. The new thing in the definition is epilepsy cured. So if the person has been seizure-free for 10 years, of which the last 5 years have been without anti-seizure medicines, then we say that the person has been cured of epilepsy. Then, of course, comes the classification and the terminology, which was there in 2017. So from 2014 to 2017, and it has been simplified like anything, because we now have just 3 seizure categories: focal seizures, generalized seizures, and unknown seizures. And each of them can have these etiologies. It can be structural, it can be genetic, it can be infectious, it can be metabolic, or it can be unknown. So, of course, the epilepsy, those were the seizure types. So, the seizure or epilepsy types can go on to focal epilepsy, generalized epilepsy, combined generalized and focal epilepsy, and unknown. So basically the seizure type followed by the epilepsy types, which are very, very simple to remember. Then, of course, the epilepsy syndromes. What is new in this classification is the addition of comorbidities. So whenever we see a person with epilepsy, we should also look at the comorbidities, whether they be behavioral, whether they be psychiatric, whether they be related to, cognition. And the focal seizures. So focal seizures are those seizures which arise from a very small area of the brain, a focal area of the brain, and they don't involve the whole brain, but they can involve focal or regional circuits. Whereas generalized seizures are those seizures which involve the global network or the whole brain. So those are generalized seizures. So focal onset and generalized onset and unknown onset. Now focal, which involve only focal networks, have been further subclassified into those focal in which the patient is fully aware. The patient is able to tell us about the aura, whether it's a sensation of fear, whether it's a hemisensory aura, whether it's a strange burning smell, or it's a ringing sensation in the ear. So that's focal. And the patient is able to tell us. So there is intact awareness. So that is focal intact aware seizure, which is otherwise in short written in OPD cards now is FIAS. That is focal aware intact seizure. Whereas focal impaired awareness is the patient has a focal seizure, like twitching of the face and the hand, and there is altered sensorium, or the person is not responsive. So that is focal impaired awareness seizure. And each of these can be motor onset or non-motor onset, and focal can become bilateral tonic-clonic. So it's very, very simplified. Generalized onset can be motor, generalized tonic-clonic, or non-motor where there is absence. And the use of the term petit mal has been given up. We don't use petit mal anymore. We just use the term absence seizure of generalized onset. And unknown is because either the eyewitness is not able to tell us the history, or even after telling the history, we are not able to decipher what kind of seizure it is. So focal aware, focal impaired aware. So motor onset, motor can be with automatisms, which can be unilateral or bilateral, can be atonic, can be clonic, can be stiffening, epileptic spasm, can be hyperkinetic, can be myoclonic or tonic. Non-motor onset can be autonomic with behavioral arrest, cognitive, emotional, and sensory. So this is to tell you about the focal seizures. Now, so atonic seizures and epileptic spasms, it's very brief, and it's not always possible to know the level of awareness. And cognitive seizures usually impair the cognition. So there'll be impaired language, impaired memory, impaired, the emotions like déjà vu or jamais vu. The term complex partial is no more used. Simple partial is no more used. Petit mal is no more used. Psychic seizures is not used. So all these terms have been, avoided in the recent classification. Then, of course, comes in 2022. In 2022, we have the division of the syndromes according to the age, whether the onset is in the neonate, whether the onset is in the infant, whether it's in the child, adolescent, and adult. And here you can see 3 categories which are listed out, which are focal epilepsy syndrome, generalized epilepsy syndromes, and syndromes with developmental and epileptic encephalopathy, where the underlying epileptic discharges are responsible for a developmental issue or encephalopathy and progressive deterioration. That is a developmental epileptic encephalopathy, and this is a huge chunk of mostly childhood onset syndromes. Whereas the generalized epilepsy syndrome will have onset at 10 years of age or beyond that. So generalized absence epilepsy, juvenile myoclonic epilepsy, generalized tonic-clonic, and the epilepsy with eyelid myoclonia, myoclonic abscences. And then you have the focal epilepsy syndromes, which can be self-limited epilepsy with centrotemporal spikes. So Rolandic epilepsy term has been gone out. It's self-limited epilepsy with centrotemporal spikes, which is SELEX, and self-limited epilepsy with autonomic seizures. And some of these can occur at a very young age, below 10 years also. So this helps us define the epilepsy syndromes. Now, in our country, we have half a mobile, we have half a epilepsy monitoring unit in our pockets, in all homes, because our country has the widest distribution of network and mobiles. So if the patient is having recurrent seizures, the relatives can bring the video to us, which will help tell us that it's a focal seizure. So here they were telling it's generalized, but when you look at the video of the mobile, it's clearly a left focal seizure with impaired awareness. The person is not responding. So it's very easy now to know whether it's a true seizure. It's also easy to know whether it's a psychogenic seizure on the mobile, because the eyes will be closed. There'll be bizarre movements. There'll be pelvic thrusting. There'll be prolonged episodes which will go in favor of psychogenic seizures on the mobile. So always ask your patients to make a recording on the mobile. What is important is that the CT scan be the initial investigation in a single seizure or 2 seizures. But if the seizures are highly recurrent, then you need to do a 1 millimeter section MRI. So 1 into 1 into 1 voxel based MRI, which is known as the epilepsy protocol MRI, which according to the International League has to be done for the poorly controlled epilepsies. A thick section MRI of 5 or 10 millimeter will not work out for these patients who are coming again and again with seizures despite being adherent. And this protocol is known as the harness protocol. The radiologist must know of this and must be aware of this protocol. We now have new drugs available to us, and we now have the pharma companies coming to us and telling us prescribe brivaracetam. Well, brivaracetam is, more penetrating into the CNS. It crosses the blood-brain barrier 15 to 20 times higher than levetiracetam. It works via the SV2A mechanism, but its safety in pregnancy is still not known. So for young girls, it is better that they continue with levetiracetam so far as the data on brivaracetam is not known to us. Cannabidiol is still not available in India, but is being used abroad, particularly for Dravet syndrome and Lennox-Gastaut syndrome. Cenobamate is a new drug. It will be coming shortly into India, and it is supposed to be the most potent drug among the new drugs. Eslicarbamazepine has an added benefit of a long half-life and lesser rash. It is available in our country, and we should be able to use it in those patients where it is required. Now, the other one is lacosamide. Lacosamide is a very good drug for focal seizures, and it acts via the slow inhibition of the slow excitation of the sodium channels and also the CRMP. We use it extensively for focal seizures, and it can be used as a monotherapy there. Perampanel is also to be used both in polytherapy and monotherapy, is allowed now in India, and it prevents the secondary generalization, that is focal to bilateral tonic-clonic seizures get drastically reduced by perampanel. The advantage of perampanel, it's a single dose at night, 2 minutes before sleeping. It has a long half-life of 106 hours. So this is another new drug. And of course, some of them are still not available, like rufinamide and stiripin. Now, among the older drugs, we must realize that there can be issues with the aromatic compounds like carbamazepine, phenytoin, and phenobarbital, because we know carbamazepine is associated with a rash, particularly in Southeast Asian population. Though traditionally Indians are not Southeast Asian population, HLE type, which is the 1502, can result in rash, which can sometimes be fatal, like if the patient develops TENS. In our population, what we found is that we do not have 1502, and routine testing of this 1502 will really not help distinguish this. But to be on the safer side, it's good to tell the relatives that if there is a rash, stop the medicine and come back to us immediately so that we can give you another medicine or avoid the medicine like carbamazepine and phenytoin. What is also important is that we have moved into an era of precision-based therapy, particularly in childhood and young age epilepsies, where you find that the epilepsies are not responding. There are precision-based therapies, like for focal epilepsy with speech disorders, where there are grid mutations. We can use, designer drugs which are repurposed for epilepsy, like memantine and dextromethorphan. And for GLUT1 deficiency, they respond beautifully to ketogenic diet. And focal cortical dysplasias respond to everolimus by reduction of seizures. Similarly, the KCN2 mutations respond to diaminopyridine as well as retigabine and quinidine. Why I'm stating this is that in childhood epilepsies, which are highly recurrent, it is now recommended to do a gene panel by a whole exome sequencing or clinical gene sequencing. It is expensive, but if any of these particular findings are there, like a KCN2, there's a possibility of giving these unique drugs which are repurposed for stopping their seizures. It's also important to remember that in Dravet syndrome, we should avoid sodium channel blockers like SCN1A, and they can worsen the seizures in Dravet syndrome. Whereas voltage-gated sodium channel in SCN2A will, stop the seizure. So one needs to know whether it's SCN1A or SCN2A. And this is only possible by doing the genetic test. For example, SCN2A and SCN8A will respond exquisitely to phenytoin, whereas SCN1A will worsen with phenytoin and carbamazepine. Hence, whenever a child comes where there is worsening of seizures with starting carbamazepine, always think of the possibility of these entities. The other thing which I want to communicate to my physician and medical colleagues is that we have a vast array of anti-seizure medicines, and now we know the safety profile of these medicines in pregnancy. It is very important to remember that many drugs can cause fetal malformations. When I was training, we had only 3 drugs like phenytoin, carbamazepine, and valproate. But now we have safer drugs and we know their safety. The safest drug so far is levetiracetam in all registries. So levetiracetam is probably as safe as having the same rate of malformation, if not less than the general population. So is lamotrigine. So levetiracetam and lamotrigine are to be used in pregnancy of women of childbearing age. Valproate, avoid it. It's also important to remember that the lower dose is better. So if you're forced to use valproate, because valproate is the only drug that the patient is responding to, then it is better to use less than 600 milligram. I put off my video because the internet is unstable. So use less than 600 milligram where the malformation risk will be lesser. So some women, they respond only to valproate. There I use up to 400 milligram of valproate because I'm forced to use it. It's like, okay. It's very important to give only low dose folic acid because high dose folic acid is associated with higher chance of malignancies as seen in this large cohort. It's not exactly known whether it's the same in our population, but we can give half a tablet of 5 milligram to all our mothers even before they conceive. So before they conceive, it should be started. The other change is the definition of management. T1 is the time before which we should act to stop the seizures, whereas T2 is the time beyond which, if we fail to act, there is a permanent damage, neuronal loss, and changes due to hypoxia in the brain. The T1 for generalized seizures is 5 minutes. So generalized convulsive seizures, where the hands are convulsing continuously, they should be stopped within 5 minutes. And that is why it is essential that we have intranasal preparation given to all our prescriptions of epilepsy patients, so that in case they have a status at home which is prolonged beyond 3 or 4 minutes, the parents are able to act before 5 minutes and give it intranasally. It's very important to definitely stop the generalized seizures before half an hour, because after half an hour, the generalized convulsive seizure, the T2 sets in when there is permanent damage to the brain. It's also important to try to make out whether the status is focal or generalized, what does the EEG show, and what is the etiology. For this, we should be aware of the classification of seizures, which is both convulsive and non-convulsive status. So this is just to show you the timeline. The timeline of 5 to 10 minutes is very sensitive and sacrosanct. Established status is within half an hour we should act. And of course, refractory status is when your drugs, that is 1 midazolam or benzodiazepine and 1 anti-epileptic, fail to act. That's refractory status. And super refractory is when we have given an anesthetic agent and despite that the status is continuing, or when we withdraw the anesthetic agent, the status is continuing. It's very important to grade the severity of the status because that will demonstrate the prognosis. The parents and the caregiver need to know the prognosis, because if the prognosis is bad, they should be told upfront and not as a surprise when some bad event like a mortality happens later. It is very good to know, based on the ESET trial, that levetiracetam is as effective as phenytoin. We have virtually stopped using phenytoin because phenytoin requires monitoring of blood pressure and in elderly, even the ECG and the heart rate. So levetiracetam can be used as the first line, valproate can be used provided there's no hepatic involvement, and phenytoin can also be used in few. It is important to have a status protocol, and this status protocol must have the doses written. So you can take a snapshot of this. The doses are mentioned. This is a protocol we use at AIMS. The exact doses must be known by the on-call or the service doctor so that the seizures can stop. And first, of course, I have written phosphonate here, but invariably we are using levetiracetam to the dose of, 60 milligram per kg. In patients who are not responding to 2 or more medicines, one must refer the patient to a center which works up patients with drug-resistant epilepsy. So any patient who's not responding to 2 or more medicines which are being taken regularly, and you have ruled out pseudo seizures, please refer them to centers where high center like NIMHANS or AIMS or Sri Chitra, where a workup for drug-resistant epilepsy can be done. And I don't know why these lines are coming on my slides, but these are definitely not my lines. And because the outcomes for surgery are very good. In obese patients and in patients who are not responding to medication, we can prescribe them drastically low carb diets, and we can also prescribe them high protein diets, which are somewhat like the modified Atkins diet, which can bring down the seizures as we have shown. So it's not just medicines, it's medicines plus diet. And this diet we did not have when I was undergoing training. We never were able to tell. It's very important that we emphasize to our patients, particularly those who are not adherent, that seizures can be fatal, and there is something known as, SUDEP, because sudden unexpected death in epilepsy is a reality. And for this, it is essential that we provide information to them so that they are adherent to the medicine. It's also important to know that once you provide them the information, there is a decrease in anxiety and an improvement in the adherence, as seen in our study. It's also important to educate patients about epilepsy. That is what Epilepsy Day is about. They should not have misconceptions. They should understand it is a controllable disorder, just like asthma, just like diabetes, just like blood pressure. It's very, very important that we educate them and give them the right information. That is our job, because if we do not do that, then they go to non-qualified people or unqualified people and get the wrong information from them, or they have a hearsay from neighbors, and there is a stigma and there is a discrimination which sets in for these patients. So education given to them is very useful in improving the outcomes of epilepsy. It's important that we communicate to our people with epilepsy in a language that they understand, through comics or by movies or by TV shows, so that they understand that the doctor community is with them on their management aspects of epilepsy, both medically as well as socially. There are many more new things coming for epilepsy. I'd conclude now, and I'd like to take questions because that will make it more interactive. Thank you.
Thank you, madam, for your wonderful, thought-provoking, exhaustive lecture.